we're stopping for a break, but I can go ahead and move on to primary CNS malignancies, which is really kind of the meat of what most people think of what this review course is about. So, you know, as you go studying through this for this examination and next year's examination, which again is hard to actually resolve some of this issue, but I think it's regardless of the disease site that you're in, what you should always be thinking of is, okay, epidemiology, presentation, workup, management, outcomes, toxicity. Running through that kind of set for each of the disease sites, whether again it's whether CNS or other diseases, is how I would focus my studying for this examination and as a review after you make it through this one for next year's examination. Okay, so with that in mind, the brain tumors actually represent a very small proportion of all cancers, and it's 2% of all cancers, and that's just for some relative stake, maybe 1/5 of as common as breast or lung cancers. There are about 23,000 new primary brain tumors diagnosed a year. However, if you in lump in both benign and malignant, it's nearly doubles. There's a lot of press these days and about increasing frequency. There is a lot of being pushed about how young people are aging quicker, if you've seen that in the news. But most certainly one of the rationales for this is increased use of screening, MRIs and CT scans, as many of these things may be found incidentally, particularly when we look at some of the benign tumors. There is a male predominance with malignant tumors slightly, and in the benign cases, a female predominance when we look at gender distribution. Caucasians are typically have primary brain tumors more often than Black patients, and the peak age for all tumors are about 50 years old. So I think this is it has been out long enough, and obviously the nuances and knowing everything on this table is beyond the scope of why it's being presented. But it is important to know that the World Health Organization's actually released a new classification systems of CNS tumors, and this was this primarily affected the glioma subsets, and so there are diffuse gliomas, IDH mutant oligodendrogliomas, and glioblastoma IDH wild type. But then there are those other primary things, and that is looking at gliomas, and we'll dive into the glioma characterization even more. But we're not going to, in your studying both like this year and next year, the adult type gliomas are important. Pediatric, it might be worth knowing about, especially diffuse midline gliomas and the genetic alterations in them, the H3K27 mutations. And then things about ependymal tumors. They've gone about a reclassification. We'll hit a little bit on that. As well, we will hit a little bit on pineal tumors, not so much because it's an important topic, but in trying to be thorough in our discussion here, in line with the reclassification of these. So malignant brain tumors, again, a majority of brain tumors as a grouping are non-malignant meningiomas. In fact, that is the most common brain tumor, is a meningioma. And then there is a sizable chunk of a non-malignant pituitary tumors. As you can see, a majority of the brain tumors are indeed non-malignant. And then this is kind of the distribution of all the other things, with glioblastoma being the dominant primary CNS tumor. Gliomas then are 80% of primary brain tumors. They're astrocytic. And these have been traditionally histologically graded with the what before the kind of the reorganization of tumors graded, although the grading still kind of follows some of the histologic variants, especially on the border between grade 2 and grade 3 in IDH mutant gliomas. These still are important criteria for grading tumors. That is atypia, mitoses, endothelial proliferation, and necrosis. So you have grade 1 pilocytic astrocytomas, grade 2 that display increased cellularity and atypia. Grade 3 have certain criteria for looking at mitoses. And then histologically, glioblastomas have traditionally been all of those other things, but required necrosis and endothelial proliferation if we were diagnosing a histologic GBM. Oligodendrogliocytes are low-grade, anaplastic, and mixed. Although mixed is losing favor in the clarification, and then ependymomas are gliomas as well. Much of we know about the grading and an astrocytoma versus an oligodendroglioma have significant prognostic implications with respect to median survival. So astrocytomas may grade 2 may have a 6 to 8 year survival. Oligodendrogliomas 12-year survival. Now recognize this is before some of the trials that we have currently out there now, or that are mature, that actually have examined things that have significantly prolonged median survival. But it does follow in this that oligodendroglioma really has the best prognosis of any of the primary gliomas. So now we're looking back, we're kind of homing in a little bit more on the new WHO classifications, particularly with respect to the glioma subtype. So it is indeed the first decision tree is a molecular based question is IDH status. So as you recall, and we'll look at it in a little bit here, about looking at a new drug that's been sought for FDA approval and impacts the IDH. IDH, as you remember from biochem, isocitrate dehydrogenase, is a critical metabolic enzyme in the Krebs cycle. And the first decision is you have is there a mutation in IDH 1 or 2, and is that that portends further grading and histologic definition. It is important to realize that sometimes the first tier of looking at this is looking at antibodies that are specifically used to pick up the most common IDH mutations, but there are clinical scenarios in which the picture is not meeting what is coming out, and it is possible to do sequencing to look for less common IDH mutations. So let's say we have the first thing, IDH mutant gliomas. The second question is do you have a 1p19q co-deletion? 1p19q co-deletion is the hallmark of an oligodendroglioma. There are a combination of high mitotic activity, various necrosis, and various molecular studies that allow us to grade this as a grade 2 or grade 3. Therefore, all oligodendrogliomas are IDH mutant. This is an important concept. Astrocytomas that are IDH mutant and are been found to be 1p19q non-co-deleted, so intact, are then looked at for various similar set of both histologic and molecular characteristics, and can be graded as a grade 2, grade 3, or grade 4. And then any species that has an IDH wild type, it goes down the pathway of being a molecular GBM, and by definition are a grade 4 tumor. So let's start with, let's make our way in a little bit into the low-grade gliomas. So these include grade 1 astrocytomas. These are pilocytic astrocytomas, subependymal giant cells, as we talked about, being associated with tuberous sclerosis. If you remember in the last small sub-lecture that we had on generalizations about the CNS. And then they can have pleomorphic xanthoastrocytomas. These are important to recognize as disease entities, but as a radiation oncologist, we rarely see these because the management of this is, if anything, is primarily surgical, and only after multiple recurrences or patients who are not able to be operated on may we even ever see these patients. More commonly are the grade 2 gliomas. These include oligodendrogliomas and various histologic variants of astrocytomas, including fibrillary astrocytomas, protoplasmic plasmic astrocytomas, and gemcitic astrocytomas. So, like I said, pilocytic astrocytomas are rare in adults, and they often present as with headaches. Imaging, they present with this kind of enhancing nodularity, which corresponds to areas of high vascularization, and then they may have often a cystic component. These are generally in the posterior fossa. Pathologically, they are characterized by these elongated cells with fibrillary patterns, and therefore from the Latin hair-like pilo, by the pilocytic astrocytomas. There's an abundance of Rosenthal fibers here that are characteristic in this disease, and loose glial tissue punctuated by vacuoles. These red areas here. The treatment is a gross total resection if possible. However, upon a subtotal resection or recurrence, the treatment decisions pending clinical context include observation, re-resection. There's scant data for chemotherapy, and then there is some data for treating these tumors with radiation therapy, both conventionally with the margin, and or even because they're so rare, there is some scant evidence on the use of stereotactic radiosurgery in the cases of subtotal resections in these patients. So oligodendrogliomas, again, they can be grade 2 or grade 3. There's no change in the histologic criteria in the recent WHO codifications. Important things, again, are ideation mutation status. So they are only oligodendrogliomas are always IDH mutant and always 1P, and this should be 19q co-deleted. There are the two diagnostic options are oligodendroglioma IDH mutated 1P 19q co-deleted if the entire workup is performed to determine that. And then you can also have oligodendroglioma not otherwise specialized. Sorry, not otherwise specified. So this is a kind of a diagnosis that is based solely on classical histology, and we'll look at that in a bit, but no molecular testing done, or in some cases, like I said, that the testing is inconclusive. For instance, the patient's tumor has the look of oligodendroglioma. They've been screened with an antibody that doesn't pick up the IDH status. However, it is so strongly thought, both imaging and histologic, to suggest that perhaps there's a non-cataconical mutation for which there's been no effort to sequence the patient's tumor for that. There is no option to diagnose oligodendroglioma IDH wild type. So that is an easy thing to test and an easy thing to know, that there's no such thing as an IDH wild type oligodendroglioma. And the term oligoastrocytoma is no longer used as a legitimate diagnosis. Any part being a little bit of an oligodendroglioma is enough to really manage it as a oligodendroglioma. 1p19q co-deletion is the definitive molecular signature of an oligodendroglioma. And as if I haven't said it enough already, all molecular oligodendrogliomas are 1p19q co-deleted and are IDH mutated. So this is the histologic appearance of an oligodendroglioma. It is the classic fried egg appearance with a prominent nucleola and almost a vacuolated cytoplasm. This is what fluorescent in situ hybridization looks like when it's performed. These are fluorescent probes for 1P is the red and 1Q is the green. So in this panel, 1Q is the positive control. So this has to show that there's actually two 1 chromosomes in these samples. Okay, each of them have that. But the test question is, do they have a 1P? And there is no corresponding 1P here. So this is the positive control. This is the test to show that there's no 1P. Likewise, this test is performed with using probes for 19q. Again, you have to have a 19q positive control. That's where the two things are in the cell. And here you can see it's missing a 19q. So taken together, this is what it could very well be done with 4 different probes on the same samples. But this indeed is how they look at 1p19q co-deletion. So low-grade gliomas, like almost any low-grade process, are generally present with more indolent. The onset is more subacute. They generally present with seizures, headaches, nausea, vomiting, altered consciousness, mental status changes, or if they are in particular areas that are, as we looked at in the overview, where the tumor is anatomically portends some of its symptoms. So, sensory loss if it's in the sensory cortex, aphasia problems if it's in Broca's or Wernicke's areas, and visual and spatial dysfunction if it's, say, in the occipital lobes. So again, these have all implications, that initial lecture on how these tumors can present and give you a hint anatomically of what's going on. Looking at the imaging, for low-grade gliomas. Multiplanar MRI with or without contrast demonstrate well-circumscribed, solid, often rounded type lesions on MRI. They're generally hypointense on T and T1, meaning there is no enhancement. They're hyperintense on T2 and flare sequencing. Okay, like this. This is actually T2. You can see that the CSF signal has not been subtracted out. And then on contrast, they don't tend to uptake contrast. You can also see them even on a CT scan. Sometimes we'll look at this, but sometimes you see that there's calcifications. We'll go into some things for some mind jogs for knowing those lesions that are on the differential with calcifications. Other tests can be, again, CT scan, MR spectroscopy, PET scan. These are generally not used in the upfront setting unless there's some confusion as to whether this is, an infection or like multiple sclerosis or something like that. So as you get into the diffuse astrocytomas, the pictures are very the same on T2 signaling. You can see some flare that's due to this infiltrative signal in this, but again, they generally don't take up contrast. There have been a lot of trials in low-grade gliomas that are important to understand historically the significance of these trials. And again, they're pretty old, but EORTC 22844. This actually looked at randomizing. This was a dose escalation study. They looked at clinical outcomes of patients treated with 45 gray or 59.4 gray. And there was no significant overall survival or progression-free survival with these patients. This is why there's a large spectrum of acceptable doses for which to treat low-grade gliomas, and that is anywhere from 45 gray to 59.4, although that dose is often saved for higher grade tumors. And so another study looked at the dose escalation, looking at 50.4 gray versus 64.8 gray, and there were no differences, no statistically significant differences in overall survival. But again, once you going to that 64 gray dose volume, those patients had higher toxicity. This also showed that 93% of the patients, and this is true with nearly all gliomas, are in field failures, with only 3% and 2 cms of the radiation field, or 3% within, and 5% were outside of 2 cm of radiation field. So patterns of failure studies, that's another driving thing across disease sites. The patterns of failure studies are what drive radiation field. Okay, so but it's important to recognize that these two trials, and we'll look at them here, actually produce some classic prognostic factors, which we'll look at, of which really none of them are used today, at least in NCCN guidelines for the management of low-grade gliomas. But EORTC 22845 looked at observation versus 54 gray in post-op setting. There was no difference in overall survival. However, there was an improved progression-free survival in patients who got early RT versus late. And it's important to realize that 65% of the patients in the observation arm ultimately got radiation therapy. So this argues that, you know, there may not be a tremendous problem waiting on these patients. And more importantly, the thought is that as a tumor is left inside the brain to grow, that is the possibility for that tumor to become undergo malignant transformation. And this study showed that there was actually no difference in the rate of malignant transformation between those patients who were treated immediately versus those that were treated only upon recurrence. So again, these EORTC studies did indeed produce a number of important prognostic factors. So tumor dependence, so histology, if patients have oligodendroglioma or mixed oligoastrocytomas, remember a term that's not used anymore, but historically had favorable outcomes. Size less than 6 centimeters was an important thing. Molecular markers, if patients had 1p19q code deletions and IDH1 or 2 mutations, did better. Again, these were not used in the definition of this. These were all based initially in these studies on histologic appearance and grading. If the tumor didn't cross midline, patients had better prognosis. If there was no enhancement on imaging, they did better. Patients less than 40 with a KPS greater than 70 did better. This is actually one of the ones that are that is retained in going forward in this population of patients. Performance status, seizures opposed to headaches, opposed to paresis, presented better, probably because these patients had tumors in eloquent areas for which they were tripped off earlier, which meant they usually had more tumors that were less than 6 centimeters, and therefore that's probably why the site of presentation or the seizures of presentation connotated a better prognosis, because that was probably a harbinger for having lower size. Patients who were steroid dependent did worse, and then patients who had so another prognostic factor were the extent of surgery. So patients who had a gross total resection did better than partial resections, and those that had radiation therapy upfront did better. So classically, how these things are treated have been involved field 3D conformal radiation and sometimes IMRT. Patients are CT simulated supine with an occupous mask. This is sort of the vernaculum for next year. They'll ask you how you supine, you simulate them, and so this is where I tell people too is if you see technique sections that people describe this year for your exam, they can easily you can revive these things for next year's studying and actually create scripts for yourself. So you would say something like, these patients are simmed in supine in an aquapos mask, MRI is fused, then I contour the T2 abnormality containing the tumor plus a 2 cm margin to block edge and give that 54 gray and 30 fractions. If the tumor has been completely resected, the target volume will be the surgical defect and any T2 abnormality surrounding the defect, again with the margin to block edge. The margin 2 centimeter to block edge is extremely generous if someone's using IMRT, but that you know, it comes down to your practice at that time. So so the real important study, the one that you should definitely be aware of some of the logistics of is RTOG 9802. This is a study, a phase 2 study of observation in favorable low-grade gliomas and phase 3 study of radiation with or without PCV chemotherapy in unfavorable low-grade gliomas. Okay, so patients who had high risk, and we dropped all those other prognostic factors that we took before, and really now the only high risk factors are those age greater than 40 and or a subtotal resection or a biopsy. Okay, so they got randomized to radiation alone versus radiation plus PCV chemotherapy. this has been, this is the follow-up at 11.9 years, the Kaplan-Meier curves. I think this is a little bit overwhelming. I think it's better for us to kind of look at what does this all really mean? Okay, so the RTOG has shown better and better outcomes even as the longer follow-up we have. So the update in 2016 showed that the separation and progression-free survival curves of the two treatment groups did not begin until 2 to 3 years, which again suggests that although approximately 25% of the patients in each group had progression before then. So if you didn't progress early, then the curves start to split. The median overall survival is 13.3 years in the radiation plus chemotherapy arm versus 7.8 years with the radiation therapy alone. That's an enormous benefit. There's no reason why these patients should be treated not treated with chemo and sequential with radiation followed by sequential chemotherapy. The rate of overall survival at 5 and 10 years was 72% and 60% in the groups that received radiation therapy plus chemotherapy versus 63 and 40% in the group that received radiation therapy alone. The treatment effects appear to be largest in patients with oligodendroglioma or oligoastros in a patient with IDH mutations. So now we're starting to find out that IDH, again, what they end up doing is they start finding prognostic factors, and then they follow the prognostic factor, and then they actually start stratifying on prognostic factor, and that's how trials almost always go in an disease side. So although there appears to be a small cohort of patients with grade 2 gliomas who do not benefit from radiation therapy plus chemotherapy, the identification of those patients remain elusive. And so you know, that's further study. So PCV is a pretty rough chemotherapy regimen. As you imagine, most people don't get through it. And so there's always the look to see if temozolomide can substitute PCV. There was a trial, RTOG 0424. This was not a randomized study. Patients were treated with temozolomide and radiation therapy, and the outcomes were compared to those of historic controls, so not a randomized control, but 129 patients with low-grade gliomas with 3 or more risk factors. Okay, those go back. Now we're moving back to the EORTC risk factors. Okay, we're treated with radiation, 54 gray and 30 fractions, and concomitant and adjuvant temozolomide. Patients had a median follow-up of 9 years. The overall survival compared very favorably. In fact, they were actually better than pre-specified historical controls. So although there is no head-to-head combination, it is felt that the outcomes of the studies are good enough to warrant this as temozolomide is being a adequate treatment for substitute for PCV. Going back to IDH. IDH1 plant is in the cytoplasm and IDH2 is in the mitochondria. It's an enzyme that converts isocitrate to alpha-ketoglutarate. Alpha-ketoglutarate acts directly on alpha-ketoglutarate dependent deoxygenase enzyme, okay, TET methylcytosine and histone lysines within the nucleus to control epigenetic landscape and regulate gene expression. So when you have mutations in these genes, okay, you get conversion of alpha-ketoglutarate to D2-hydroxyglutarate, and this accumulates within the cells and competes with alpha-ketoglutarate to inhibit these things, these growth control processes. Okay, so D2HG accumulates within cells, and this causes accumulation of methyl groups on DNA and histones, which leads to changes in gene expression and causes these cells to differentiate. So these are epigenetic mechanisms. And so we actually now have a targeted agent that has recently been shown in studies to improve outcomes in low-grade gliomas. So this was the Indigo trial. I think it's worth knowing this study because it's going to be such an enormous change in how we manage it in IDH mutant gliomas. The progression-free survival is significantly improved in the vorasidenib group as compared to the previous placebo groups, 27 months versus 11.1 months. Okay. The time to next intervention was significantly improved in the study arm. Okay. Adverse events of grade 3 or higher were higher in those that received the study drug, but and there was an increase in liver enzymes. So based on this very encouraging data, the FDA has granted priority review to vorasidenib in IDH mutated diffuse gliomas. This priority review was granted in February of 2024 this year, and you should watch for this drug to hit the clinic soon. This is a good break point. Does anybody have any questions so far? So I guess I'll type them in the chat, John, and you'll read them, or what?
They'll type them in the chat, and you should be able to see the chat, but if you're having problems, I can read them if need be.
Oh yeah, here go. Okay, I'm seeing the chat, but I'm not seeing anybody there. So all right. So we'll move on to the high-grade gliomas here. Their presentation is very similar to that of the low-grade gliomas. I think it's more the how rapidly they may progress from nothing to something less insidious kind of onset than the low-grade gliomas. Headaches, nausea, vomiting, cardinal signs of increased intracranial pressure. And then depending on where they are, as we discussed before, it would be, weakness, sensory loss, aphasia, gait instability, things like that. So the imaging is a little bit different. In the grade 3s, you might have nodular areas of enhancement from neovascular formation, and along with that, leaking of fluid into the interstitium or edema. Grade 4 gave a heterogeneous enhancement, areas of central necrosis. Widespread increased T2 or flare signal, suggesting infiltrating tumor and or edema associated with that tumor. We looked at this again. This is amen. We have atypia mitosis, like might be here, endothelial proliferation and necrosis. This is a classic sort of necrosis with this viable cells around there forming these pseudo-palisading necrosis and vascular proliferation around that central kind of necrotic tissue, as if the tumor is growing so quick as to not be able to keep up with the formation of the blood supply despite its best attempts. And this actually has some implications for the use of bevacizumab, how the glioblastoma makes new vessels, but those vessels are poorly formed and also very susceptible to hydrostatic changes that can result in edema and things like that. So surgical intervention before radiation improves outcomes. Okay, that's as you'll see, the script for next year is a patient. We asked the neurosurgeon for a maximal safe resection. The advantages of extensive resection are you get enough tumor for molecular analysis. You can detect an oligodendroglioma compartment with 1p19q testing. Obviously, the neurological changes are much more rapidly reversed if they are destined to be improved than with radiation alone. Decreased risk of epilepsy, increased overall survival with greater than 90% tumor removal. We'll look at some of the early Kaplan-Meier data with the extent of resection with glioblastoma soon here. So that's a preview of coming attraction. And it also facilitates adjuvant treatment. It may get cells cycling again that are residual and therefore potentially more susceptible to radiation and or chemotherapy. And here it is. This is prior, it's 2011, prior to Stoop data, but it's still, the goal is, you can see that you get spreading of the survival statistically significant between a 78% resection and an 80% resection, and then it even starts to split between 90, 95, 98, and 100%. So the goal here is always maximal safe resection. So we're going to look at some of the anaplastic oligos and anaplastic oligoastrocytoma trials. There was a slight difference in how the ERTC did it versus how the RTOG study. The ERTC looked at radiation 5940 in 1.8 gray fractions, followed by 6 cycles of PCV. And the RTOG looked at and this randomized it versus radiation, neoadjuvant PCV followed by radiotherapy. And the final report has just been published here recently. I'm sorry, I don't have the reference, but it's actually quite recently. Both studies studied radiotherapy with and without neoadjuvant, adjuvant, procarbazine, lomustine, and vincristine for newly diagnosed anaplastic oligodendrogliomas. So the ORTC study had 14-year survival and probable 20-year overall survival rates without versus with PCV were 2.6 years, 13%, 14-year survival, and 10%, 20-year survival versus median survival of 3.5 years, 25%, 14-year survival, and 16% 10-year survival. With a 1p19 code deletion, the median survival is 9.3 years and 26.2% and 13.6% versus 14 years, 51% and 37%. So again, the 1p19q codeletion, non-surprisingly from what we've seen from the low-grade glioma standpoint, is prognostic for grade 3 oligos. There were similar outcomes seen in the RTOG study, suggesting that the order of the chemotherapy versus the radiation probably doesn't matter that much. And again, they did find an improved benefit for patients with 1p19q deletion. So there are 2 trials that we're going to look at here, and some of these are really kind of messy because what happens during the study period is this maturation of other studies going on and adaptation of that, and probably what we're going to be seeing is more adaptive trials in an attempt to speed outcomes with it. So the Catanon trial was a phase 3 trial of concurrent and adjuvant temozolomide chemotherapy in non-1p19 deleted anaplastic gliomas. So this was the schema initially here. And so without the loss, and they got radiation, initially radiation plus concurrent temozolomide, radiation versus to adjuvant temozolomide, okay, and RT with adjuvant and concurrent temozolomide. In 2021, we had an interim analysis in response to emerging molecular data, the Cat-9 study protocol was amended to include analysis based on mutational status of one IDH1 and one IDH2. So they amended it because they were learning more in trials that were becoming mature. So in second interim analysis with follow-up of 27 months and median follow-up in 55.7 months, the futility of the concurrent temozolomide was reached with 66.9 months with concurrent temozolomide, worth 60.4 months without concurrent temozolomide. Adjuvant temozolomide, so that was concurrent. So adjuvant temozolomide improved overall survival compared with no adjuvant temozolomide. Okay, the treatment of temozolomide alone of newly diagnosed patients with 1p19q co-deleted WHO grade 3 oligotumors was associated with significantly inferior progression-free survival compared with RT. Okay, and when combined with prior reports, results support the assertion that current standard of care for newly diagnosed 1p19 co-deleted anaplastic closures should include both radiation and chemotherapy. So that is parallels that with what we saw in the low-grade glioma trial. Then there was another study that came along, this time for the co-deleted group, or the CODEL trial. It was initially a phase 3 intergroup study alone of radiotherapy versus temozolomide alone versus radiotherapy with concurrent and adjuvant temozolomide in patients with 1p19 co-deletion. So this is what the initial schema looked like here. But RTOG 9402 showed that patients with co-deletions of chromosome 1p and 19q experienced superior overall survival following treatment with both neoadjuvant PCV chemotherapy and radiotherapy as compared with radiation therapy alone. So they're waiting for 9402. This came available, so they said, oh no, we better switch things up here because it might be unethical to keep people on study arms that have subsequently shown to be better. So they eliminated the temozolomide arm alone. So this one went goodbye. Okay. As it was unlikely to demonstrate that treatment of temozolomide only was of clear benefit to patients. So they reorganized it, got rid of this this thing, and then they went back and they looked at just these two sets of people, the radiation to PCV versus radiation plus temozolomide onto temozolomide. Okay, so so what they found is 83.3% progressed with temozolomide alone, and 25% deaths from aggression versus 37% progressed with on the RT arms. So they're still carrying forward that. That's why they got rid of it. They're still reporting the outcomes. There was no difference in overall survival. Even when adjusting for IDH status, progression-free survival is less in patients not getting XRT. No difference in neurologic decline between the two arms. And this is recently published in 2021. So, you know, this is still very much, I've seen people, they really have, with grade 3 oligos, still recommending this here or this. So we still don't have a clear picture of the temozolomide use adjuvantly versus concomitant and adjuvant. Switching gears here to GBM, the groundbreaking trial, unfortunately, has really not been anything nearly this impressive since then, was the STOOP trial that looked at 573 patients, and it was a trial versus of radiation plus or minus temozolomide. The temozolomide, I think this is fair for oral board examinations. The temozolomide was administered at 75 milligrams per meter square concurrently all 7 days during radiation. And then adjuvantly was increased dose for 1 to 5 days for every 1 to 5 every 4 weeks for 6 to 12 cycles. interestingly, and maybe not always now, that we see that leukopenia, which sensitizes patients to, and especially lymphocytopenia, to PCP pneumonia, patients are prophylaxed with inhaled pentamidine, but now actually the recommendation is Bactrim. Benefit of the combined modality treatment was seen in all prognostic groups. However, the MGMT methylated status was the strongest predictor of outcome. So you can see how dramatic the improvement in survival is with the addition of temozolomide in the combined chemoradiation arms. Temozolomide is an important drug to understand. It's in the purview of medical oncologists, but I think its actions on radiation are very important. So it's an oral alkylating agent that's given as a prodrug, and it methylates basically the N7 and O6 position of guanine. Okay, and what happens is so temozolomide is a methylating agent. And the methylating agent methylates DNA. So that actually targets the DNA for so the MGMT, the temozolomide methylates DNA. The enzyme that unmethylates or undoes that DNA damage is methylguanine methyltransferase. So MGMT works to undo the damage that temozolomide did to DNA. That damage is to methylate DNA. In an epigenetic fashion, and totally separate methyl groups, patients may, or tumors may or may not have methylation in the promoter regions of the gene for methylguanine methyltransferase. So if patients are hypermethylated, they do not produce as much MGMT, which means more of the damage to DNA remains as a result of the actions of temozolomide. And therefore, patients who have hypermethylated DNA have more DNA damage, and therefore their tumors respond better to radiation, and that is how it's all sensitive. So there's a lot of methyl groups in here. It's a methylguanine methyltransferase enzyme, okay, that takes off the methyl groups that the alkylating agent temozolomide put on DNA. And if we look at the prognostic significance of MGMT silencing by methylation, there's if you produce the MGMT, therefore temozolomide is not as effective, your overall survival is 11.8 months. But in those patients who got methylated and got radiation plus temozolomide, their overall survival is significantly higher, 21.7. This trial, I mean, this study and the adjuvant studies that went looking at post hoc analysis of methylation status, and there's really forms the backbone of the standard of care management for glioblastoma today. However, there are a number of recent negative trials which are at least worth knowing about. The first one was RTOG 0525, which basically asks the question, if temozolomide is more temozolomide better? So it was dose-intensive temozolomide versus standard adjuvant temozolomide. And there was no difference in overall survival or progression-free survival. This study found validified the prognostic significance of MGMT, and of course, not unexpected was the increased grade 3 toxicity with twice as much drug. Then there was looking at adding bevacizumab. Remember that high-grade gliomas are characterized by significant neovascularization, but those blood vessels are poorly structured. And the idea is that perhaps if you normalize that blood vessel formation, that you can actually like help the tumor. In fact, bevacizumab is a legitimate agent used in the salvage of patients who recur with GBM. And so looking to add it in the upfront setting, however, did not improve survival. And as well, there was an increased symptom burden, a worse quality of life, and decline in neurocognitive function were more common in the bevacizumab arm. So not only did it not improve survival, but it actually made patients' quality of life worse over time. Because we looked at a reducing agent, MGD, metaxaphin GAD. This was given with temozolomide in the upfront setting, and all this showed that the drug was tolerated, but it didn't do anything. And then velparinib, a RNase PARP inhibitor used in other disease sites these days, was looked to see if there was a difference when added in the treatment of GBM. Again, this was another disappointing lack of development in GBM. So, the 6-week course of radiation therapy is long, especially if you have older patients with challenges to getting to clinic every day, and 6 weeks. So there was an ERTC study. There's actually been a few of these studies that looked at a hypofractionated regimen with radiation and temozolomide in these patients, 40 gray and 15 fractions to the tumor plus 2 cm margin. So the outcomes of this were that in elderly patients, the addition of temozolomide to short course radiation resulted in longer survival than short course radiation therapy alone. And so even if you're going to do a patient with short-term radiation therapy, they should be getting temozolomide as well. Another trial more recently looked at the addition of lomestin, another alkylating agent, to temozolomide in patients with GBM. There was a small single-arm phase study that showed adjuvant temozolomide radiation and temozolomide compared with lomestin in newly diagnosed glioblastoma. There was a median overall survival of 34 months versus historical controls in patients with MGMT methylated promoter, that this formed the foundation for a phase 3 study that again looked at patients with newly diagnosed MGMT promoter methylated GBM to treatment with RT and lomestin plus temozolomide versus RT and temozolomide alone. Analysis was done on an intention to treat. The overall survival on the combined alkylating agent arm was significant, but the progression-free survival did not improve, which was thought to be because of this thing of pseudo progression in the temozolomide plus lomestin arm. This will come back to with pseudo progression in a minute here. Not unexpected was the fact that grade 3 and 4 adverse events were slightly higher in the combined effort, but the difference was too small to actually identify a difference. So there was an analysis of health-related quality of life showed no differences. And so if we look at, this is a legitimate treatment option that is phase 3 data suggests improvement in those patients with MGMT promoter methylated glioblastoma. I promised a discussion on pseudoprogression, which is very important. Pseudoprogression is the post-radiation treatment radiographic changes following local glioma therapy, mimicking tumor progression. As it is diagnosed by imaging changes only, it is inherently a retrospective assessment. So there was a study in Brandeis by Brandeis et al. That showed 108 patients treated with tested had MGMT methylated tested 36 or 35% of them had MGMT methylated tumors. 1 month after chemo-RT, 49% had apparent disease progression. Temozolomide was continued in all patients. 64% of the 50 had repeat imaging that showed stable and improved disease. This is, again, a hallmark of pseudoprogression, and you almost have to have additional study to show that retrospectively that what you were looking at was a pseudoprogression. Of the 32 patients with pseudoprogression, 2/3 of them had methylated MGMT. Pseudoprogression is seen up to 30% of all patients after the first MRI. Pseudoprogression more often in tumors with MGMT methylation. Okay, and disease progression is more common 3-to-1 in unmethylated tumors. So what I tell people is this is a very complex subject, and I always tell patients with who are getting treatment, because I've had patients really mad at me when they got a hold of the report immediately the first MRI following chemoradiation for the GBM that actually is read as worse than they were before it all started, and they're really upset and said, well, why did I do all this if it's even worse than, and the idea is that the pseudoprogression may represent an exaggerated treatment response, because if you actually have pseudoprogression, you live longer. So even though it may be a hot mess on an MRI, I do tell people that it's probably best thing to do is, if they can deal with the uncertainty of what's going on, that they should root for the hot mess. This is what it looks like on a time course. So there is this is acquired prior to surgery, and then 4 weeks after the completion of radiation, actually kind of looks a little worse, right? And then there's partial regression of the enhanced lesion at a lighter time, 6 cycles after adjuvant, and you get this kind of decreased, and this is by definition pseudoprogression. This is, again, is the time course for which you might expect to see pseudoprogression. You go to surgery, okay, you get your post-op MRI. Sometime between 2 and 6 weeks, you start the chemoradiation, and 2 to 4 weeks after, you get this first post-treatment MRI. Okay, 50% look stable. The other people look worse. And so of those people who get worse, half of those ultimately get stable or better, and this is defined as pseudoprogression. Unfortunately, still a quarter of those people have progressive disease, even very early after frontline therapy. Visiting our old friend, the MR spectroscopy, if there is doubt and as to what might represent progression versus pseudoprogression, MRI spectroscopy has a high sensitivity and specificity to determine treatment effects versus recurrence. So if you do single voxel MR measurements, you can see that recurrence has a pattern that's characterized by increased choline and decreased creatinine ratio, decreased creatinine resulting in an increased ratio. And but radionecrosis has a very flat signature with respect to those metabolites that you'd expect to be seen with growth, like choline and increased lactate, indicative of necrosis. So the next thing that we see in the addition of radiation or in the management of glioblastoma is the addition of Optune or tumor treatment fields. It was initially approved for salvage in radiation therapy. What it is alternating electric fields that are thought to disrupt the spindle apparatus within the tumor cells. Patients wear a array on their head that's designed based on where their treatment was, and they wear this power generator and a battery pack, and it's worn for more than 18 hours a day. The head has to be shaved. The EF-14 trial was a phase 3 study that compared temozolomide, completed radiation plus temozolomide and randomized them to TTF plus temozolomide versus temozolomide alone. Should note that one of the so anyway, there was a statistically improved overall survival at 2 years with the addition of Optune. Now, so much so has this gained so much traction that it actually is now either methylated or unmethylated treatment, that the category 1 recommendation is to actually add alternating electric fields. Now, the primary, as you may be aware, the primary argument with this is, you know, if you're wearing something on your head 18, 20 hours a day, that's pretty diligence. And the trial was not done in which they made people wear a sham control, right? That would have been kind of unethical. But are we not just selecting for highly diligent patients that might have sought out an aggressive surgery earlier, or would have been more intact with their in touch with people because they were noticed something earlier because they're a type A person or whatever. So none. That's really not an argument for me. I sell it to. Not sell it, but I introduce it to all my patients and let them make the choice. Just so you know, there is some data looking at that's been released recently at looking at tumor treatment fields in the management of brain mets from non-small cell lung cancer. Now, invariably, your patients will fail. A great majority of them will. I do have, as you may have yourself, some, well, not this early in your career, but maybe from residency, have seen long-term survivors. But ultimately, patients will develop a recurrence that's a bona fide recurrence and not just pseudo progression. And the management of those patients is highly variable. The RTOG attempted to address this with the randomized phase 2 trial of concurrent bevacizumab and reirradiation versus bevacizumab alone. I told you bevacizumab alone is a valid salvage for treatment failure. And they looked at this for patients with recurrent glioma. You can see that they were stratified here by performance status and age. The median follow-up of 12.8 months, there was no improvement of overall survival with the addition of radiation to bevacizumab, but there was an improvement in progression-free survival. The 6-month progression-free survival rate improved from 29% to 54%. So overall, reirradiation was shown to be safe and well tolerated. Bevacizumab plus RT demonstrated a clinically benefited, meaningful progression-free survival, but no difference in overall survival. So that you know, there are different schemes for reirradiation, but in this particular trial, they used 35 gray and 10 to the cavity plus a setup margin, or to the enhancing disease or setup margin. So I think that there's a lot to go in reirradiation, but for good for highly well-performing patients, this is indeed considering retreatment, especially if it's after 6 months, is a very reasonable thing to offer. So some designer things here. We have this gamma tile, which is the CNS brachytherapy of, there's a tile in a surgical matrix with cesium that's impregnated in there, and this has been shown. The FDA cleared this in 2008 for recurrent brain tumors, and upfront in any malignant brain tumor came in 2020. The textured surface and smooth surface. The textured surface faces the operative bed at the implant, and this is the surface that has 3 millimeter offsets from the cesium seeds. They have a fixed source, and the gamma tile design and source strength results in a physical dose of approximately 60 gray to a depth of 5 millimeters in the brain. So this is a really good way of getting dose in recurrent tumors, and studies are being performed now in the upfront use of this, even in the upfront use of glioblastoma on a trial basis. So as you can see, there are numerous trials. This is just a smattering of the things for what newly diagnosed recurrent GBMs, so even some new brain tumors, resected brain tumors. So something to watch, something to at least know about here. So just a couple more glioma things, or at least primary brain tumors. So we should talk a little bit about diffuse midline gliomas. The diffuse midline gliomas typically arise in the midline structures such as the brainstem, pons, and the medulla, the thalamus, spinal cord or pineal region, cerebellum, hypothalamus, or third ventricles. Symptoms are usually attributed to brainstem involvement, so they may have ocular nerve problems, coordination issues, other cranial nerve defects, or even signs of obstruction. The adult diffuse midline gliomas have less IDH1 and IDH2 and AGFR alterations compared to high-grade gliomas. And H3K27 mutations have different oncogenic drivers than its wild-type component. H3K27 mutant adult diffuse midline gliomas have a worse prognosis than pediatric one. There are some agents like ONC201 that specifically target this genetic alteration that are accruing, but I think it's important to know about this disease entity not only in the child but in the adult. Ependymomas are another thing that a primary brain tumor that has seen some reclassification in the 2021 WHO classification. There's a slight male predominance in patients with ependymomas. They're about 1.7% are I'm gonna come back to your question when we're done with this. Okay, about 1.7% of all CNS tumors, a peak incidence in early childhood, but it can occur at any age. Most common primary spinal neoplasm. Adults, median age are 30 to 40 years old. 50 to 60% are in the spinal cord. There's an increased incidence of spinal cord ependymomas in patients with NF2. So 2/3 occur in the posterior fossa. So this is a supratentorial posterior fossa, and here's a spinal ependymoma. Japan is noted for having more often supratentorial ependymomas. In the spinal, they're more frequently adults. They're intermedullary versus, and sometimes they could be in the cauda equina, which is true often of myxopapillary ependymomas. 1/2 of all spinal tumors are ependymomas, except for in kids. 2/3 of cauda equina tumors are ependymomas. Supratentorial lesions, like this one here, can be intraparenchymal due to the embryologic, and we talked about way back in the beginning that the embryologic development, some of these ependymal cells get trapped in the actual parenchyma, and even though they're not lining the ventricle, they can become transformed during and develop into ependymomas too. The clinical presentation depends on where it is, right? So you could have hydrocephalus, you could have a syrinx in the spinal cord, and this can result in focal signs or motor sensory defects. 8 to 30% of CSF spread at presentation. So particularly if it's in the posterior fossa. So staging of the CSS recommended with CSF cytology and a SPREN and brain MR. This is actually what we have now in the WHO characterization, and we have molecular subgroupings within each component. As of yet, there's really no specific therapy that's targeted for this, because in general, ependymomas are not treated with chemotherapy, and so the prognostic significance may be there, but in terms of looking at these different times in terms of treating them different, there's no reason to think that there is a difference. So prognosis wise, the worst prognosis are patients who are very young or very old or older. The best prognosis are older children and young adults, and they can have an overall survival of greater than 16 years. Spinal tumors do better than intracranial tumors. Infratentorial tumors do better than supratentorial tumors, and patients with gross total resections are better than subtotal resections, both in pediatric and adults. In adults, 5-year overall survival for intracranial ependymoma is 60 to 80%. Poor prognostic features are some of these locations and the extent of resection, and then some of these things that were used to develop molecular subgrouping. Local tumor progression remains an issue in up to 50%, in most of these ependymal tumors, with up to 50% recur even after post subtotal resection. And so if we look at how the NCCN suggests that we manage these patients, we have if you have a grade 2 or grade 3, standard radiation, we tend to don't observe one of those. Although if they did have a gross total resection, it might be reasonable for a grade 2 tumor. And then the myxopapillary is now its own grouping. These are generally higher grade. In fact, they are by definition now a grade 2. Our bias at our institution is to offer radiation to these patients, although that is an active question. If patients have CSF spread, they should be getting craniospinal radiation. Chemotherapy in ependymomas, in general, adjuvant chemotherapy after surgery and post-operative has not been shown to be beneficial. High-dose chemotherapy with stem cell rescue has not demonstrated a benefit. Best activity, but short duration responses can be seen in platinum regimens. High response with multi-agent regimens. In general, adults is limited with extrapolated. Sometimes patients use temozolomide or alkylating agents, or even bevacizumab. There's an increased interest in molecular targeting, especially when patients have next generation sequencing for targeted therapy. So let's continue on here. Pineal region tumors are the next group. And this is not to belabor the point, because I think these are pretty rare. But there are germ cell tumors we know occur in the pineal things. So that's a group to know about. Pineal parenchymal tumors are pineal parenchymal tumors, pineoblastoma, papillary tumors of the pineal region, other rare tumors, and then you can have actually metastasis to the pineal as well. When you look at general overview of the management, where you have pure geminomas, okay, treatment strategy, radiation with chemotherapy as an exclusive treatment, non-germinal cell postoperative RT, okay, pineal blastomas, okay, pineal parenchymal, these two, the postoperative RT, papillary tumors, the pineal tumors, you can give radiation of incomplete resection. Pineal cytomas are sort of, it's usually radiation is reserved focally and surgically unresectable cases. So let's go back to this one question. The question is, are IDH wild type diffuse midline gliomas similarly more aggressive like in high grade gliomas? Well, so I think that these if we look back here, I think that what's fair to say is that they have different drivers. I don't think we have a lot of information because this is kind of a relatively new entity defined based on its H3K mutations. I think what I'm asking is the most aggressive of these molecular subtypes. I mean, I think that if you have the wild type IDH, that similarly you get the same epigenetic phenomena that you get in low grade gliomas. So having an IDH mutation, an IDH wild type, the problem with that is that you generate all these other species that allow for different pathways. I don't think it's, if we can look at, you have IDH, you have a midline glioma with IDH positive or not, mutation or not. I think that it has more avenues. I think in general, it would probably be more difficult to control with those tumors that are managed with chemotherapy. But I think that what's the driver really in terms of prognosis is the location of it and the amount of radiation that you can give. So I think that that what it is we don't have enough data yet, but I think it's more a real estate phenomenon, making it aggressive and how well it responds to radiation separately from whether you can target it. Now, will agents that target IDH have an impact on it? I think that might give us the answer that you're looking to. I don't think we have that answer now. All right, so let's move on to the next presentation.